as a follow from Dr. Tzikas, who he told us everything about the theoretical part from the LAAO occlusion. I'm now going to show you a case that was performed in our hospital. It's about a 66-year-old male who is under oral anticoagulant therapy with apixaban 5 milligram twice a day. The reason is the persistent atrial fibrillation that he's having, but unfortunately he suffers of recurrent severe gastrointestinal bleedings with habefol and transfusion need. His Chatzitofi score is 3, and his Hasbled score is 4, and that is translated into that he's in a higher risk for major bleeding, and we should advise him, or we should take into consideration alternatives for anticoagulation. An alternative is the LAAO occlusion. In order to do that, we have to screen first the patient. One way of screening, we could do a CT scan in order to see how the morphology of the left atrial appendage is. As we can see in this picture, and of course in the TOE, but I'm coming there next, we have a windsock-shaped LAA. And afterwards, before we did the LAAO occlusion, we had a TOE screening, where it's very important to see if there is any thrombi in the LLA or we have spontaneous echo contrast, because of course we are working in the LLA and we do not want to mobilize any thrombi in the arterial system. In the TOE, we do also our first measures. A very important measure is the area of the LAA ostium and also the length of the LLA in order to choose the right device. That could also be done in the 3D reconstruction, where we also can measure the AVA from the LLA ostium. Taking consideration the high Hasbled score from the patient and that he's suffering from gastrointestinal bleedings, we did decide that we want to do a transcatheter left atrial appendage occlusion. We do that while the patient is intubated, and afterwards we do a puncture in the right femoral vein. Of course, under echo guidance, and we do insert a sex French catheter. We go then with the catheter with a guide in the right atrium to the vein, and we go and we have to do for first the transeptal puncture. It is very important that we are away from the aorta, and it's very important to do the transeptal puncture in the fossa ovalis in order to do not have any pericardial effusion. As we can see here, first the tenting from the needle, and then we go through the septum in the left atrium. Afterwards, as you see here, we are inserting a wire in the left upper pulmonary vein in order to have stability. Afterwards, through the catheter, we insert pigtail catheter in the LAA, where we do flash contrast agent, and with this flash we can measure once again the length and the LLA ostium, the area, in order to be sure that the device that we selected is the correct one. We did select in this patient an Amulet 25. It has two parts, this device, one lobe that is going in the LLA, as we see here, and one disc that is that occludes the LLA ostium. So under echo guidance and also under fluoroscopy, we are inserting the amulet in the LLA, and we try to position it so that it doesn't have any leakage. We do then perform a 3D reconstruction as well as measurements in various grades so that we can be sure that the LLA is occluded from every aspect. At last, we do another flash from contrast agent so that we can be sure that the LLA is rightly and appropriately occluded, as we see in this fluoroscopy video here, that we see that the contrast agent cannot insert the LLA and that it's being left in the left atrium. So afterwards, we decided that as a team that that the occlusion is successful, so we deployed it from the catheter, as we see here. And here I have the end result. That's a 2D image. We see here how the LLA occlusion, the amulet is occluding completely the LLA. And here we have also the 3D reconstruction, the 3D video to see how rightly it is positioned.
So, thank you, Maria. This was a nice presentation. So, when we deal with this procedure, we always rely with what the imagers inform us. So, we need to have accurate information about the size and the type of the left atrial appendage, but mostly if there is thrombus in it or not. And yes, and how accurate is TOE as opposed to CT, the information that Dr. Vrachliotis informs us. So it's pretty accurate in both, or you think, Dr. Vrachliotis, that CT is more accurate compared to the TOE? And then, of course, we have also Dr. Nyktari. She can make a comment on that and can inform us on the usefulness of CMR in this setting.
Well, to begin with, what is your take on those places where What is your routine to begin with? I don't know your routine.
So our routine is when we screen patients, we always do a CT, because we want to properly identify the thrombus, but also to have specific information on the type of and to have accurate information regarding the dimensions and the type of the LAAO before
because
at the screen.
Oh. Okay, well, are you telling us that because we don't get too many from you?
Yes, we do from time to time. We don't have a lot.
We don't have a lot. Okay, maybe that's the reason why. So you have 1 or 2 every month?
Well, pretty much, maybe even
okay,
less.
So if you want to image and demonstrate the appendage, you have to do it right. And as you very well know, since the patient is in a supine position, if you do a first pass and you image too early, chances are that in a big atrial appendage, you will not have uniform enhancement. So there you will have a pseudo-positive result. That means to the unfamiliar eye, someone will say, okay, there's a filling defect in the left atrial appendage.
So maybe it's thrombi.
So the trick here is to wait. You know, there's second, third circulation of blood, and that will usually do the trick.
Good.
And also, it's a very, very frequent event when we're doing CT coronary angiograms, totally different for a totally different reason. It's not unusual to see that the left atrial appendage is not opacified, so there's a potential filling defect, and that's the usefulness of the second low radiation pass we do for the lungs. Personally, I have observed many times that I had a question in the early phase when everything was nice and brightly imaged, but in the second pass, in the low, with low radiation, it filled up, so there was
Good.
no...
So you should always rely on second
yes.
pass. And that's
But
proof.
if you want to do a measurement, you have to do a high resolution scan. So we need beforehand to know that, so that the second pass is done with high resolution settings.
So so if you do a coronary angiogram, a CT angiogram, of course you can still spot.
Absolutely.
Yeah.
Absolutely.
So maybe we don't need to tell you that then.
So that's extra work. Okay, fine.
If I can interfere.
Fine. We'll add another paragraph with the measurements.
Dr. Mazilis.
Thank you. We'll be happy to.
To continue from the comment I heard just as I was coming in, I think the numbers definitely are not going up, and there are many reasons for that. First of all, this is not a big cohort of patients, obviously, and the thing is that the indications were not clear. In the beginning, we were receiving patients who had thrombosis despite anticoagulants, and then obviously the indications have changed a bit now to patients who had Hasbled high score. And another reason is that we're not getting back these patients. Most of them going to other specialties, and maybe the neurologists and gastroenterologists are not convinced that this is the right treatment. Plus the fact that the medications have got better now and safer. And all of these reasons contribute to the fact that the numbers stay low.
Yeah, and then there's the issue of adherence, which of course it's a lot better compared to to the previous decade, but still there is an issue because the Greek study that Apostolos just showed us, still there is a big issue. So 30% of these patients, the Greek patients, don't take the adequate pharmacology. So this is something to be aware of. Yes. So Vaso, you.
So I think this was a wonderful session. The Kosmas suggested the selection of the patients, the candidate for the LAAO closure or the paravalvular lead closures. The devices that are coming, the new devices that are coming, and what else?
Yes.
And the communication between the experts, neurologists or gastroenterologists, in order to be
exactly. So we need to communicate each other. So Maria, thank you very much. And so we'll go directly because